Hey everyone, so I'm going to be talking with y'all about pediatric burns. So, for pediatric burn injuries, these are injuries that typically occur from accidents. They are life-altering or deadly, depending on the severity. They are the fifth leading cause of accidental injuries amongst children, and they often result in acute or long-term intensive care hospital stays, depending on the severity. Some environmental factors that contribute to burns are a lack of supervision. Um, Sometimes a kid might have easy access to what's been cooking on the stove. If mom or dad is cooking and they walk away and child is curious, so they try to see what's going on up there, and then kind of like the picture showing here, that can lead to a really bad burn. That's typically a scalding type of burn if it's from a liquid. Or if matches are left out, a candle is left unattended, this can lead to an accidental burn as well with the child just being curious, just child being a child. Um, so unfortunately, there are some accidents that are unavoidable that lead to the burns, of course, like car accidents that lead in fires or house fires. Um, the scalding flame and electrical burns are the most common amongst kids, and typically in the older, like the adolescent population, there are a lot of burns that result from fire play and risky behaviors like playing with gasoline and matches and fireworks. Um, so yeah. So these are the burn classifications. There's first degree burns, second degree burns, and third degree burns. The third degree burns are typically the ones that you will see in an acute care, intensive care burn unit. So this is not a chart that we would specifically need to fill out as occupational therapists, but it is a chart that we would need to understand when understanding the total body surface area that is affected by the burn and the severity of the burn. So as you can see on the chart, each body part is kind of sectioned off, and each body part is worth a different percentage of body of like the total surface area. So the higher percentage is the higher total body surface area affected. So this is just something we would need to be able to look in someone's chart before we go see them, just to understand where the burns are and how much of their body is affected by the burns. And just so you know, there are some more graphic photos on the next slide. These are some examples of children that have acquired first, second, and third degree burns. The picture on the right and the pictures on the bottom, they're a little more severe. But unfortunately, this is the reality of children that have experienced some level of burn injury and they have been admitted into an acute level intensive care unit. So the care team approach is critical in burn injuries, whether they are in intensive care, acute care, outpatient, or inpatient. The physicians, nurses are always going to be a very critical part. Of course, OTs, PTs, speech language pathologists, wound care folks who have special certifications to be able to do that kind of stuff, social workers or case management, the family members, other therapists that come in and treat the patients are also part of the care team, like music therapists, play therapists, or respiratory therapists, as one's respiratory system can be significantly impaired due to a burn injury. And then, of course, volunteers always make a huge difference as well. So these are just some of the precautions that we would need to keep in mind before evaluating a child that has a burn injury. We need to chart review, of course, note the burn severity, and as I was talking about that chart earlier, understand their total body surface area that's affected. We need to know what their skin condition is currently like, if they have any skin grafts, where they are, um, where their wounds are, and if they currently have any contractures or scarring. This is especially in inpatient or outpatient rehab whenever you're coming back or they're coming back to see you, you're not seeing them as consistently. You want to understand how their scarring is coming along and if it is affecting their range of motion at all. So this is the evaluation process. First, we would get that referral. We would do a good chart review based off of what setting they're in, whether that's ICU, acute, inpatient, or outpatient. Interview parents, interview the child, informal direct observation of the child in their most natural environment. Um, and that may be the hospital for now, whatever environment they're currently in and functioning in. And then some standardized assessments that we can do, which I will talk more right here. We can use the Pediatric Functional Independence Measure, the WFIM. This is useful to assess and track progress of a variety of functional abilities. And it also measures levels of assistance needed during those functional tasks. The WFM can also keep track of the severity of the disability, so this is useful to track progress over time. And then also for children that are a little bit older, the FIM is useful for them for the same reasons. And then also the Pediatric Evaluation Disability Inventory, the PEDI, is good for the same reasons. It just analyzes those functional capabilities and can help identify areas that may need new intervention. These are some affected occupations, school, of course, playing, extracurricular activities, self-care tasks, self-feeding. Not only may their range of motion and movement in general be affected because of the burn, they may not be able to swallow due to a physiological impact from the burn. They may have scarring that is impacting their range of motion, and they may also have contractures that are interfering with their ability to like open and close their hand or extend their leg fully, flex their leg fully. There's several different components that go into play here, but essentially all of their occupations are going to be impacted in some way, especially if they are admitted into an intensive care unit and or acute care setting where their entire life has completely changed. These are some of the intervention strategies that we are able to implement as occupational therapists. Um, Pain control is really important, especially in intensive care and acute care. Desensitization techniques can be important whenever scarring, whenever the wounds are starting to heal. Modalities like ultrasound, paraffin wax, soft tissue mobilization, and massage are very important. Splinting and positioning are also very critical to reduce the possibility of contractures and possible deformities due to the burn. Um, Splinting and positioning can also be helpful for edema management and maintaining integrity of joint range of motion. Mental health counseling is also important. There would be counselors available to kids and families, but we are able to apply things that we've learned to help manage emotional regulation and stress management so children they feel confident and able to participate in the things that they need to or like to do. Family and caregiver parent education is also very important. Exercise and early ambulation is critical. Physical therapists can mostly focus on this, but there will be times that occupational therapists can co-treat to address these goals of gross motor activities in order to complete their ADLs. Aquatic therapy is also good for this if you're certified in it. That helps facilitate gross motor movement in a non-weight-bearing environment. Pressure garments are helpful to reduce itchiness of the skin. And then, of course, last but certainly not least, those ADL skill training interventions. And for kiddos with burns, adaptive equipment would need to be explored most likely in order to help them regain independence. So these are some examples of long-term and short-term goals. Long-term goal one, the child will regain functional use of affected extremity to independently complete age-appropriate self-care tasks within 16 weeks. Some activities for this could be assistive device exploration for ADLs that I spoke about before, splinting and positioning, passive range of motion at first, and then advancing to active range of motion activities like popping bubbles, aquatic therapy, interactive dance, and songs, therapeutic exercises, and an obstacle course with a gradual increase in difficulty to get them moving. And then for a long-term goal number two, a child will independently engage in age-appropriate play using affected extremities with minimal fatigue to support social participation and occupational engagement in 16 weeks. So this goal was made in keeping in mind if they are in an acute care or inpatient rehab setting where they would be on a unit with other children that are able to interact with one another. So gross motor play, throwing and catching, rolling a large ball with a large group with other children. Fine motor play, like building a Lego set, creating a friendship bracelet with other children on the unit, um, playing Uno, and something like a talent show on the unit where everybody can participate and that social aspect is really emphasized. So that is the end of my presentation, and here are my references. And I just wanted to reiterate the fact that just because you have seen or worked with somebody with a burn injury, especially a child, as with every other diagnosis, everybody is different. Everyone is going to have different needs. So, really making sure that you understand um, the child, the family culture, what they want, what they need, what the child really likes, using that therapeutic use of self to create rapport to be able to ultimately achieve goals a little bit easier, is really important. So, and also just being aware that burns takes a lot of specialty training and being confident in your abilities to provide services as a skilled occupational therapist practitioner is important. So that is the end of my presentation. Thank you all for listening.